Go.
Hello, good evening. My name is Joy Monka. I'm a pharmacist. Today I will be presenting to you the use of methotrexate alone or in combination therapy. So methotrexate, it's used in a variety of populations, and today we're going to be introducing to you and using here on the patient JC. Patient JC is 70 years old, average weight, and have cardiovascular disease for 2 years now. And patient JC have a moderate disease with a pain scale of 7 out of 10. That means severe pain. So the current medication that patient JC is on today, as of today, is a methotrexate 7.5 milligram once weekly, hydrochloroquine 200 milligram BID, prednisone 10 milligram for 7 days so far because of the pain, ibuprofen 400 milligram 3 times a day, furosemide 20 milligram daily, and hydroxyzine 25 milligram 3 times a day. So patient have allergy previously, which is one of the significant past history that we know, and allergy to ACE inhibitor lisinopril that was discontinued because of cough. So today I would like to have you take on, which is the learning objective, which include memorization of the pathophysiology of rheumatoid arthritis, and identify 3 classes of medication that is used to effectively treat rheumatoid arthritis. The third point is describing patient-specific monitors as it relates to therapies to promote better patient outcome. Select appropriate treatment therapy among the demands alone, combination with biologics and non-biologics to treat patient effectively. So the question that I asked today is, what do we use to treat patient JC with patient having pain and inflammation at the moderate stage? Do we add tozolamide or methotrexate to patient therapy? So we recognize the 2015 American College of Rheumatoid Arthritis recommendation of different stages of the arthritis, early in the disease or established, which is late in the disease. The early being less than 6 months, late in disease is more than 6 months. As you see the algorithm that we're using from the American College of Rheumatoid Arthritis recommendation, with patients using the demand at early on the therapy, and the combination of among the demands that we've seen before and how it is introduced into the established stage that we have to use the biologics and non-biologics, that is after 6 months. So we look at we have different algorithms pointing to that, and also we have the instrument that is used to record patients, to record and detect rheumatoid arthritis in patients if it's early in the disease or progressive or late in the disease. If you look at the recommendation from the American College of Rheumatoid Arthritis, we see how they are classified. Look at it. If you look at it, the tender joint, swollen joint, C-reactive protein when they carry out the test. We're using the patient global assessment test, which is a 0 to 10, depending on what we get, to indicate for patient establishment of the ROA. Wow. So the quantification is calculated together. We're looking for 28 joints patient using the patient global assessment. Moving forward, when we saw that patient has 7 out of 10, which classified as moderate ROA. So we recognize the 2010 also, that's the ACR. So let me first of all back up a little bit. From here and now, ACR will stand for the American College of Rheumatoid Arthritis, Rheumatology. And so that's what when you hear me use ACR, that's what I mean. So the assessment of disease activities using the instrument. Remember the instrument we saw before, the calculation of how many joints to make 28 for us to certify that patient is established or early or established as the recommendation go. Go ahead with the question.
So, could you, I'm sorry, concerning the joints, the 28 versus less, so if it's less than 28, what does that indicate?
So if we have less than 28 joints, based on the new recommendation, we still have to treat patient and initiate the first therapy, which is the demands that I will get to soon.
Okay.
So thank you for that question. So we see assessment of disease activities using the instrument, clinical presentation of RA. It is either autoimmune disease, and it can be triggered by environmental factors. That antigen depends on patient factors. So we have both. We see different presentation, both systemic or symptomatic. So systemic include the fever, myalgia, arthralgias, decrease in appetite, and all of that you see in patients. And you see the symptoms, the joint pain, the stiffness. You see a lot of patients that have ROA, the established one. You see all those. So those are the deformities. But you see the joint swelling, which mainly the synoviitis. And synoviitis indicate that the swelling in the joint it's a swelling. The bone is inflamed, and the bones start to deform. Calcification that we see. And we use a radiograph to look at it and assess the show erosion and the malignancy of these stages in patient assessment. So at what point of therapy do we initiate medications that we're talking about today? So we look at the 2010 classification from the ACR and ELU, which is the European Union for the same thing as America. The presence of this is that ROA is the presence of synoviitis at least one joint, and one of more 6 or higher of 10 within this more specific 4 areas. So when we look at that in patients that present to us, and we are able to calculate 28. Even if we don't have enough as 28, we still have to indicate treatments because we're looking at the C-reactive protein. Because that's a flag telling us that patients have rheumatoid arthritis. And these are categorized to low, medium, or severe per validated scale that we used earlier. First line therapy options is the DMARDs. So disease-modifying anti-rheumatic drug. Usually the monotherapy, it is encouraged to use that first because patient is going to be on most of this medication lifelong. And we need to start slow, go slow, and accelerated continue to add based on clinical outcome. And so among the DMARDs, we have the hydrochloroquine, sulfasalazine, methotrexate, and leflunomide. So we have, within the DMARDs, we can do combination based. If patient is not doing well with methotrexate, which are our gold standard, we can add together among the DMARDs. We can add the methotrexate with sulfasalazine, depends on how patient feel and based on allergy.
So how would you determine which drug to use first versus the methotrexate versus the other one?
So when patients present to us early the therapy, we know to initiate methotrexate. And we can carry out a series of tests that's indicated in that table just now to see, there are questionnaires that are used among the tests, there are global studies that are used in the test to determine what stage the patient is in the rheumatoid arthritis. So that is when we initiate. Either way, we start first with methotrexate.
I have a question. So
either or we start with methotrexate. So when we use methotrexate, one second, I'm sorry. When we use methotrexate first, we see how the patient is doing because patient system has to get used to this medication. We know of the side effects, which I will get to soon, and this is why we start slow. When patient get used to this medication and patient is not doing well, then we add on. And we can actually move. This is where I'm going to with the study. Because in the late stage, we do add medications like tozolamide. You see that we have the recommendation of 2 drugs or combination among the DMARDs, and recommendation of 3 or more drugs among the DMARDs also. And we cannot add the biologic and non-biologic.
My quick question is it that once the patient is kind of at a tolerance level, you're going into combination therapy?
Yes. It is, yeah. When the patient becomes tolerant to that not necessarily tolerance. It is when we look at the patient is still having pain. Usually pain is majorly what we go to, because when patient gets effective targeting with this medication, there is resolution in pain. Because when we first introduced methotrexate, we do give prednisone, oral prednisone, to reduce pain. So now, because of the pain, we see patient with. Because the idea of treatment is to prevent destruction of the joint. Because when the joints start destroying, it is hard to reverse. That is why the initiation of methotrexate is used early on in the therapy before we add the combination of medications.
One last question before you move on.
Okay.
So have you ever tried, now we have to look at different organs, how these drugs would impact. Have you ever encountered a client who doesn't respond to therapy? Maybe this person have a number of chronic other illnesses which the liver may not be able to metabolize.
That is why
That's not within the scope of
that is why we have to use, first of all, methotrexate. Methotrexate is not working.
Mm-hmm.
We can use any other options in the DMARS category. So patients have different clinical outcomes with different medications. And so we look at interactions with different medications. We also look at how patient is doing. Sometimes if the patient is already moderate to severe, when coming into we can go straight away using tozolamide as monotherapy right away. Because we want to target, we want to avoid this the joint destruction. We want to avoid those pain because it is critical that we understand how patient is feeling. So with patient complaint, the questionnaire given to this patient, when they marked it out, they are able to tell us what they feel. And we are able to assess based on the instrument that we have to determine how we treat this patient for
you have to play with medication.
So yes, that's what is going on. Yes, thank you very much for that question. So now we have the biologics. The biologics contain the enterocept, infliximide, cetazolamide, and glucosamide. And we have the non-TNF alpha, which has the abatacept, rituximide, selusamide, and tozolamide. So let's focus on methotrexate now, which is the gold standard that we were talking about earlier. It's majorly used for mild to moderate ROA. And this medication is used from 7.5 milligrams to 8 milligrams weekly. It can be increased to 20 to 25 milligrams weekly if tolerated by patient, like we were just saying just now. And it can be added to other medications like the tozolamide or other medication, depends on how patient tolerate it. And so I would not be remiss if I don't say that because of the pathway of methotrexate, because it blocks the folate reductase inhibitor. So because it blocks it, the body is not able to make folic acid at that time. So the introduction of folic acid daily while you're taking methotrexate is very important. So 1 milligram daily folic acid should be added to methotrexate while in treatment. So the mechanism of action of methotrexate, let me go back to what I just said just now. Methotrexate acts as a competitive analog of folate blocking dihydroreductase, preventing the formation of THF and blocking purine biosynthesis. So because we are blocking that's why we add folic acid. Methotrexate also inhibits pathway in the immune cells.
I have a question. What is the role of folic acid?
So questions let's save it for the end. This is a 30-minute, but
it's 30 minutes. They're gonna go.
Yeah, so like
okay.
Yeah, I'm sorry.
So thank you very much for that question. I will answer that at the end.
Okay.
Methotrexate inhibits the pathway in the immune cell. Methotrexate is immunosuppressive, designed to slow the damage done to the joints, and they can induce remission. They reduce the frequency of flares. That is why it's always added to other therapy because it works very well. It protects the structure. And if a patient that have cardiovascular disease, methotrexate is really good. Also from their studies that indicate that it protects the heart. So let's focus on tozolamide. Tozolamide is a monoclonal antibody. It's humanized. It inhibits the binding of interleukin 6 2 at the 6th position in the pathophysiology of the patient when dealing with the joint. So it is a non-TNF alpha. So methotrexate works on moderate to severe activity on rheumatoid after the inadequate attempt of the first line therapy and other biologic agent. If it doesn't work, then we go into non-biologic, which is tozolamide. So tozolamide works in the moderate to severe active. It has been found in several studies very effective. It is dosed as 4 milligram per kilogram IV and is infused over 60 minutes. And it can be increased to 8 milligram per kilogram IV every 4 weeks if needed. The adverse events that we've seen with tozolamide include neutropenia, thrombocytopenia, dyslipidemia, hepatotoxicity. These are very critical issues. That is why we must monitor this medication when parents are on it. So what is the difference between tozolamide and DMARS, especially methotrexate? The difference is that DMARS, methotrexate, slows the damage done to joints. It reduces the frequent flare-up and it helps prevent structural damage. While tozolamide, the non-TNF alpha, inhibit the entire receptor complex, preventing interleukin 6 signal transduction. So inflammatory mediator that interact with beta cell and the T cells. So this work majorly during the moderate and severe stages. Is very good. It works. It is huge studies on it. It works very well. So let's look at the efficacy of treatment. So based on the study review that we're treating today, tozolamide plus methotrexate or tozolamide alone, if used to target patients on early stages or late stages. So the author went ahead. So let's look at it individually. Methotrexate shows statistical remission and delay in disease progression in RA patients. So with an added therapy at 24 weeks, we saw methotrexate gave a very good effectiveness. While tozolamide did not kick in well yet, and at the same time did not show equal value at that time. Tozolamide was statistically significant at targeting remission and RA, but tozolamide at a dose of 8 mg per kilogram IV every 4 weeks was added or to a switch therapy. The monotherapy was higher, showed a higher efficacy at 52 weeks, not at 24 weeks. That is the radiographic show. That is what shows us what is going on in patient's body. The combination therapy, tozolamide added to methotrexate show higher efficacy in patients at both 24 weeks and 52 weeks. That means when with patient on late stage of the disease, the addition of methotrexate to tozolamide gave a huge and a higher effectiveness in patients for remission. And so the study uses DAS28 ESRO is a scale that validates the efficacies. Tozolamide switch group did not show that at 24 weeks. That means tozolamide alone being used for moderate to severe did not show that at 24 weeks that the combination therapy showed. So now at 52 weeks they were comparable. So the addition of tozolamide methotrexate at 52 weeks showed that both of them were effective. They were combination effective. It shows that they were equally effective at the same time.
The combination.
Yes. When you use tozolamide alone or you use tozolamide with methotrexate, they show at 52 weeks they show. They show greater effectiveness. So now let's look at the intervention. Methotrexate plus tozolamide 8 mg per kilogram every 4 weeks or tozolamide switch therapy. So let's look at the outcome measure, the primary endpoint. When we use the DAS28 EARO scale, the remission rate at endpoint at 24 weeks from baseline, effectiveness was seen in group on add-on, that is the combination. Then it was showed on both 4 weeks and 24 weeks. There was effectiveness was showed for the add-on group, but not on the tozolamide by itself. So tozolamide and methotrexate add-on was, and the switch to tozolamide. So while they were using the DAS28 scale with a rate of remission at 24 weeks, there was the effectiveness of the combination was 70%, while the single tozolamide was 55%. The P-score was 0.02 at that time, with a higher efficacy or effectiveness being shown to tozolamide methotrexate. So when we look at it, at 52 weeks, we saw that the combination and tozolamide were 72 and 70. So disclosed. That means the significance of both study and the treatment were both comparable at that time at 52 weeks. So that means the combination therapy is good to be started when patients are at the moderate and a severe stage. So we look at when you look at it for the structural damage, it also reported that tozolamide plus methotrexate combination compared to tozolamide alone, structural remission was measured at 66% and 46% at 52 weeks, which showed no significant difference. So we look at the CRRP, patient was measured at the high radiographic remission. We switched therapy down, the combination therapy at 9 and 5 years. And the p-value was 0.4. So look at let's look at the adverse event. The adverse event were higher and more in the combination group, of course, because both of them have both side effect and adverse that was not combined. So but it was still better. So we saw the adverse event at 13.9% and 8.1 with combo and standalone tozolamide. So the author conclude in the finding. The combination of tozolamide and methotrexate provided higher benefit in patients with ROA. So the radiographic progression on both showed better effectiveness. Methotrexate inhibits inflammation of joints compared to tozolamide alone. While monitoring patient, that's monitor patient on tozolamide and methotrexate combination when done together. So So the dosing is clear. I said it earlier. The recommended dosing that was used for the study was 7.5 milligram to 8 milligram once weekly, and can be increased to 25 weeklies for methotrexate. And temozolomide 4 milligram per kilogram can be increased to 8 milligram per kilogram IV once every 4 weeks. Dosing can be adjusted based on patient tolerability because every patient is different. So administration of methotrexate can be IV, IM, or oral route. It depends. Methotrexate is very good. It's bioavailable to all medications. Medication does not food does not affect methotrexate. Temozolomide initial also, we also know that every 4 we have to give 4 milligram per kilogram, which work and can be increased to 8 milligram per kilogram every 4 weeks. And this administration is within 60 minutes. It's a single dose every 4 weeks. The side effect that we must monitor with these medications are heart attack, stroke, heart failure, interstitial nephritis of the lung disease, and pancreatitis. And patient need to be monitored. We have to monitor the neutrophil, the platelet count, the